Hello, my name is Olga Molchanova-Cook. I work in Las Cruces, New Mexico, and we will be talking today about neuroendocrine tumors and nuclear medicine role in evaluation of tumors. Objectives are review main imaging options for neuroendocrine tumors that we have available in nuclear medicine. That includes carcinoid, islet cell tumor, medullary thyroid cancer, PHEOCHROMOCYTOMA, neuroblastoma. Those are all tumors arising from neuroendocrine cells. We will review main radiotracers used in imaging of neuroendocrine tumors, and their normal and abnormal distribution. And those include I-123 labeled MIBG, indium-111 labeled pentatreotide, otherwise you know it as OCTREOSCAN, gallium-68 labeled DOTATATE, copper-64 labeled DOTATATE, and more common tracer that you're aware of is FDG, labeled as F18. We will also touch on radiotracers that used for treatment of neuroendocrine tumors. There are two main radiotracers that are approved by FDA. It's I-131 labeled MIBG, otherwise known as Azedra, and lutetium-177 labeled DOTATATE that you would know by name of Lutathera. So we will start with MIBG. Usually we use MIBG for imaging of neuroendocrine tumors that express norepinephrine transporter. We can use MIBG labeled with I-123. It has better characteristics for imaging compared to other option, which is I-131 labeled MIBG. So we will talk about I-123 labeled MIBG. Half-life of I-123 is 13.2 hours. Photon air energy is 159 keV, which is optimal for our cameras, which are the best sensitivity and quality of images at about 140 keV. So MIBG substance is very similar to norepinephrine, which is a neurotransmitter that's taken up by some neuroendocrine cells, which express norepinephrine transporter. So what we are imaging is cells that are capable of picking up norepinephrine by means of norepinephrine transporter. Normal expression of this transporter is seen in liver and in the heart and in adrenal glands. Those will be organs that we will be looking for when you are posed with question of what radiopharmaceutical you're looking at. So liver is the hottest. You will see uptake in the heart. That's a hallmark because not that many radiopharmaceuticals that will be picked up in the heart muscle. And often normal biodistribution, you will see uptake in the adrenal glands. It could be symmetrical, it could be asymmetrical, always has to be correlated with anatomical imaging. Also, normal uptake will be in the salivary glands, nasopharyngeal mucosa. Excreted radiotracer will be in the urinary bladder, will be a little bit uptake in the GI tract. And in this case, we are looking at a scan of young individual, probably child, and they still have plenty of brown fat. And you will see uptake in the brown fat because it usually expresses as norepinephrine transporter. And this radiotracer is used for imaging tumors expressing, overexpressing norepinephrine transporter on their cells. And these include neuroblastoma, PHEOCHROMOCYTOMA, and adrenal cortical adenoma can show increased uptake of this radiotracer. Also, tumors that may show uptake of MIBG would be paraganglioma, ganglioneuroma, ganglioneuroblastoma, and medullary thyroid cancer. So uptake in those tumors is not 100%, but if you see it, it's quite specific. You know that that's a tumor with overexpression of this norepinephrine transporter. However, many of these tumors do not overexpress norepinephrine transporter, and we'll talk later about what other options we have for imaging of these tumors. On the right side, you see normal biodistribution of the MIBG. Liver is the hottest. You see uptake in the heart immediately after you see whole body scan with heart uptake. You think about possible MIBG scan. In this case, you don't really see adrenals, but you see uptake in the brown fat in the supraclavicular regions and our usual nasal mucosa, salivary glands, and excretion in the urinary bladder. That's a normal biodistribution of MIBG. Here is an example of MIBG imaging of neuroblastoma. And neuroblastoma is a tumor of neuroblastic origin. It expresses this neurotransmitter transporter on the cell almost uniformly. It's almost always positive on MIBG. Demographics are usually, this tumor is seen in children. On cross-sectional imaging, on CT, and on MRI, hallmark of neuroblastoma, it's heterogeneous appearance. Very often it has areas of necrosis, so it will have this cystic appearing regions. Often it has calcifications, and it tends to originate from one of the adrenal glands, and when it spreads across the midline, it lifts off aorta of the spinal canal, of the spine. So you will see these features on cross-sectional imaging, and when we imagine it with MIBG, we will see intense uptake in the tumor. And you see example on the right, on CT scan, heterogeneous mass in the left renal fossa, and it crosses midline, lifting off aorta of the spine. On MRI, you can see this heterogeneity again with cystic areas and crossing midline again. And in this patient, you also see lymphadenopathy and paraspinal masses in the chest. And on the top right, MIBG whole body scan shows heterogeneous uptake in the tumor. You can see it the best on the posterior view. You can see a heterogeneous uptake in the region of the chest, which corresponds to the masses, paraspinal masses that we see on MRI on the lower images. And it looks like maybe there are some bone lesions. You can see uptake around the knee in the around the left knee on the MIBG scan on the top right. Most common origin of the neuroblastoma would be paraspinal regions of the chest and abdomen. For exam purpose and for your reporting purpose, you need to know staging of neuroblastoma, which features you may be asked on the exam about, and which features is important to report when you're reading scan with neuroblastoma in your future real life as a radiologist. So usually tumor staged by 4 different stages. What's important is crossing midline, not crossing midline, presence or absence of metastasis. Those are 2 features that are important to mention in the report. Also, presence of the lymph nodes on the same side or on the opposite side. And for neuroblastoma, there is additional stage. It's called 4S. It's a disease-specific type of neuroblastoma, which is seen in children younger than 1 year old. And it usually presents with metastasis to bone marrow, to the liver, to the skin. Sometimes it's called like blue muffin baby, because those bluish skin lesions make it like look like a blueberry muffin. And it's important to know this stage because it has totally different prognosis, different from regular stage 4. On this graph, you can see that 4S stage is right there at top, green line, and it looks like prognosis survival is similar to stage 2 of neuroblastoma. Interesting saying that in some children, it can actually spontaneously resolve, even though it's by definition metastatic tumor. but it has totally different prognosis, and you have to be aware of it, and it's often tested on the exam. MIBG can also be used for imaging of PHEOCHROMOCYTOMA, PARAGANGLIOMA, ganglioneuroma. Most of those tumors express norepinephrine transporter on the cell surface. And just a refresher, there's 10% rule for pheochromocytomas, 10% extraadrenal, 10% bilateral, 10% malignant, found in children, familiar, not associated with hypertension, and contain calcification. So this is another piece of information that is highly tested on the exams, and you need to be aware of it, especially in your future life. You will see especially extraadrenal and bilateral pheochromocytomas. And on the right side, you see image anterior and posterior view MIBG scan. In this case, you cannot really see uptake in the heart. So it depends on innervation of the heart. So good that it's not on the exam to ask you what kind of radiopharmaceutical it is. But you can clearly see on the posterior view that there is a big mass in the region of the right adrenal gland, and it shows very high uptake of radiotracer, which clearly exceeds uptake in the liver, so it's abnormal. It's consistent with pheochromocytoma. And you can see on posterior view on the left side, there is uptake probably in normal adrenal glands. That's how uptake in normal adrenals usually look in the adults. Another version of MIBG could be labeled with I-131. You can still use it for imaging, but you know that images of I-131 are very grainy, very low resolution, so we really don't use it for imaging. What we use it for is for treatment. I-131 is beta emitter predominantly, and we can treat these tumors that express norepinephrine transporter on the cells. So if you image this patient and you see that, like in previous case, high uptake of radiotracer MIBG in the tumor, it means that you can deliver beta emitter in high concentration into the tumor. So in these kind of cases, we will offer this patient treatment with Azedra, I-131 labeled MIBG. Azedra is FDA approved for treatment of tumors that positive on MIBG scans. You do a MIBG scan, you determine avidity of the tumor, and you treat them. It's approved only for adults and children older than 12 years old. It's usually used for pheochromocytoma, paraganglioma, and neuroblastoma treatments. And again, refresher, I-131 is predominantly beta emitter, beta minus, and it also has gamma photon at 364, and half-life is 8 days. 364 is very suboptimal for imaging. As I mentioned already, images will be grainy. The best sensitivity of our cameras is about 140 kV. And here is an example of patient with probably neuroblastoma or pheochromocytoma. In the right retroperitoneum, you can see imaging with I-123 labeled MIBG on the left, high avidity of the tumor, and multiple metastases looks like in the bones and probably in the mediastinum, probably in the lymph nodes. And then we treated this patient with 300 millicuries of I-131 labeled MIBG and took an image like we do after iodine treatments and thyroid cancer. It's the same I-131, so we can take picture after treatment, and we see that there is a very good uptake of radiotracer in the main tumor and in the metastasis. And then 1 year after treatment, we re-imaged this patient with I-123 MIBG, and we can see that metastasis uptake is significantly decreased. We still have uptake in the main tumor, but it appears smaller. At least we got rid of majority of the metastasis. So it does work. It's not perfect, but it was a good choice to treat this patient. Significantly decreased volume of disease. Another group of radiotracers that we use for imaging of neuroendocrine tumors are radiotracers based on imaging of somatostatin receptor. There are many cells in the body that express somatostatin receptor on the surface, and many tumors that overexpress this receptor. And example of this would be carcinoid, that's the most common one that we would image with this kind of radiotracer. Also, many of the islet cell tumors express somatostatin receptor, medullary thyroid cancer, PHEOCHROMOCYTOMA, PARAGANGLIOMA, and NEUROBLASTOMA. I already mentioned that PHEOCHROMOCYTOMA and NEUROBLASTOMA type tumors, sometimes they do not express much of norepinephrine receptors. But in those cases, they may express somatostatin receptor. So we can, if you have negative scan with MIBG, you can always try to image it with somatostatin receptor targeting radiotracers. The main radiotracers that FDA approved and used for imaging of this kind of tumors is indium-111 labeled OCTREOSCAN, gallium-68 labeled DOTATATE, which is called NETSPOT. This is PET radiotracer. And another recently approved PET radiotracer is copper-64 labeled DOTATATE. Its brand name is DETECTNET. And again, we did the same trick as with MIBG. We have the same octreotide type substance labeled with beta emitter with lutetium-177. So we got DOTATATE labeled with lutetium-177, and we can treat tumors that express somatostatin receptors. And this is FDA approved, and this treatment is called Lutathera. So we'll talk about OCTREOSCAN first. It's labeled with indium-111, can be imaged on our regular gamma cameras or SPECT cameras. Indium-111 is a long-living isotope, so you can image a patient at 24, 48, sometimes 72 hours. As long as it takes, as long as it increases your specificity and your confidence in the findings. Thing is that longer you image, later you take images, then washout from the normal organs will decrease background activity, but activity in the tumor will remain the same. So you will have sort of improved tumor to background ratio uptake, and it will be better visible on the background. If there are especially small tumors in the pancreatic head, sometimes it's difficult to see them on the background of bowel activity, and you might want to add more images. Usually my technologist calls me at 48-hour image and asks me if I want to continue, if I want to bring patient back for 72-hour image. So indium-111 half-life is 67 hours. It emits photons with energy 171 keV and 245 keV, which is quite good for imaging. We get nice and sharp images. And on the right side, you see normal biodistribution of indium. I usually remember that indium likes spleen. So you see spleen, and it's the hottest. So you have to think about radiotracer that labeled with indium. So when you have question what radiotracer it is, and spleen is the hottest, think indium. And the hallmark of OCTREOSCAN is spleen and kidneys. If on posterior view your hottest organs are spleen and kidneys, you know you're looking at OCTREOSCAN. There is no other scan that looks like that. Spleen and kidneys, remember that. It's like Antmini, you have to remember it. It's nothing else that looks like it. And of course, normal uptake is again nasopharyngeal mucosa, because it's a big molecule, it goes to the liver. You will have homogeneous moderate uptake in the liver. At 24 hours, you will see radiotracer in the colon, and it will be excreted in the urinary bladder with urine. And it has appearance very similar to MIBG and may be confused with MIBG, but MIBG usually will be in the heart, and OCTREOSCAN will not. And another difference is kidneys. Kidneys will be bright on OCTREOSCAN, but will be very, very faint or not even visualized at all on MIBG. So liver, spleen and kidneys is OCTREOSCAN. Heart and liver is MIBG scan. OCTREOSCAN is based on imaging of expression of somatostatin receptor. This substance itself is very similar in its structure to octreotide, which is used for treatment of this kind of tumors, of carcinoids and other neuroendocrine cancers. And in this case, we are targeting somatostatin expressing tumors. The most common you will see imaging with OCTREOSCAN when we are looking for like base of mesentery mass that difficult to get biopsy, and differential diagnosis includes carcinoid, and we will offer OCTREOSCAN. If it lights up, we know that it was carcinoid. Here is an example of patient with lung carcinoid. And you can see that we used indium-111 pentatreotide, 5 millicuries. We imaged patient at 4 hours and at 24 hours. And as I mentioned, that with delayed images, there is washout of radiotracer from surrounding tissues, and conspicuity of lesion itself increases. And it's clearly seen on this exam. At 24 hours, lung lesion uptake is much better seen compared to 4-hour image. And in this case, we acquired SPECT images and SPECT CT and superimposed it on each other. And you can clearly see that uptake corresponds to the lung nodule in the left upper lung field. Looks like it's left upper lobe. And it's consistent with somatostatin receptor expressing tumor, most likely lung carcinoid, and it was proven to be lung carcinoid in this patient. Here is another example of somatostatin receptor expressing a neoplasm. In this case, it's PARAGANGLIOMA, even though name suggests that it's not carcinoma, but they can be malignant too. In this case, you're looking at the scan of widely malignant paraganglioma, which expresses somatostatin receptor with multiple lesions in the bones, in the liver, in the mediastinal lymph nodes. And it looks like there is a big mass in the pelvis. I think I remember this patient. It was a young girl, and she had this humongous mass in the pelvis. She had those bumps on her head. And overall, this tumor was not really growing at all for many years, even though it was metastatic. It was quite an interesting case. So paragangliomas may not pick up MIBG, and they may pick up OCTREOSCAN. So keep in mind, those two radiotracers can be used for imaging of PHEOCHROMOCYTOMAs, paragangliomas, and neuroblastoma type tumors. And here it is, example, octreotide normal uptake versus MIBG. And that's what you might see on your exam. And you can see octreotide spleen and kidneys, very typical appearance. And MIBG liver and heart. Again, liver, heart, MIBG, spleen and kidneys, octreotide. So remember this, they like to test you on the exam on the normal biodistribution of different radiopharmaceutical, and they may ask you to identify what are you looking at. Now we are moving forward with somatostatin receptor imaging with PET tracers. One of the PET tracers approved, I think, last year is gallium-68, labeled DOTATATE. brand name is NETSPOT. And it's used for staging, restaging, evaluation for recurrence of tumors that express somatostatin receptor. Again, DOTATATE is based on octreotide type substance that binds with high affinity to somatostatin receptor. And it's essentially the same as OCTREOSCAN. It's just PET version of it. And with all PET scans versus SPECT scans, you know that PET scans provide much better resolution. And because it's usually PET-CT, it gives you very good localization. And you can see that the same on the right side on the image, the same patient was imaged with indium-111 OCTREOSCAN versus gallium-68 NETSPOT. And you can see that you can easily miss all those liver lesions in the liver when you are looking at the OCTREOSCAN, but they're clearly visible on the PET-CT scan on the right side. Normal biodistribution of NETSPOT is quite similar to what you usually see with OCTREOSCAN because we're targeting the same receptors. And again, it's spleen and kidney is the hottest. Liver has moderate uptake. And interestingly, we see uptake in the pituitary gland. So no uptake in the brain, pituitary gland uptake, spleen and kidneys. That's a normal biodistribution. Here is an example of imaging with new radiotracer, which was just approved by FDA for imaging of neuroendocrine tumors. It's the same DOTATATE, but labeled with copper-64. And it's PET radiotracer. And again, it provides all those advantages of PET-CT imaging. And you see that biodistribution, again, is quite similar to other octreotide-based substances. Spleen is the hottest. In this case, kidneys are not that hot, but you still see on the cross-sectional images that kidneys do have uptake. It's just not that obvious on the MIP on the left because of patient having this widely metastatic disease in the bones. So it's quite similar. Copper-64 is slightly easier to handle. That's why we expect that maybe it will replace gallium-68. Gallium-68 generators are difficult to operate. Not for us. Usually it's operated by radiopharmacies. But for example, in my area, we don't have a gallium generator. So we're looking forward to imaging with copper-64. And now let's look at the treatment option for tumors that express somatostatin receptor. Again, like with other imaging and treatment coupled modalities, here we have the same substance, DOTATATE, and we attach beta emitter, lutetium-177. And we have Lutathera, which is FDA approved for treatment of somatostatin receptor expressing tumors. There is also option of DOTATOC, which is similar substance, to be labeled with yttrium-90. It's in the research. I don't think it's actually FDA approved for use, for overall use in treatment. You have to understand advantages and disadvantages of different radionuclides attached to the ligands. Lutetium-177 versus yttrium-90. They are both beta emitters, but they have different half-life. Lutetium half-life is 6.7 days. Yttrium is 2.7 days. It means that lutetium will stay and radiate those cancer cells longer, versus yttrium will have high dose rate. It will deliver its dose in shorter period of time. So it depends what you want to do. Lutetium has advantage of gamma emission, so we can image this patient after we deliver dose to confirm that the dose was delivered to correct tissues to where we wanted it to go. You don't have that ability with yttrium. Usually, after treatment of liver tumors with yttrium labeled like TheraSpheres, or you will see only bremsstrahlung radiation, but you cannot really image it properly. So it's another advantage of lutetium-labeled substances. And another thing is energy of the beta emission. In lutetium case, you have path length in soft tissues of about 2 millimeters, versus in yttrium case, it's 12 millimeters. So again, if you administer lutetium, you will have less collateral damage. If you administer an yttrium-labeled substance, you will have more collateral damage. But on the other hand, if you're dealing with big tumor, which is partially necrotic, which has altered delivery of radiotracer to the center of the tumor, maybe you do want to use yttrium and to have higher, bigger radiation range. And in those cases, maybe you do want to have yttrium-labeled substance to be used for treatment of the patient. So yttrium-90 DOTATATE is not really used. It may be approved soon, but lutetium-177 Lutathera is available in many big centers, and it is FDA approved. And it was shown to improve patient progression-free survival and decrease risk of death when you use Lutathera versus standard care before Lutathera was just octreotide treatment. So it's very promising, very successful treatment that we offer into our patients. And I highly advise that in your practice, you try to establish treatment center that offers this option to people with metastatic neuroendocrine tumors. An FDG PET that you see probably every day. You can use FDG for imaging of neuroendocrine tumors. FDG is labeled with F18, is analog of glucose and approved for imaging of cancer. F18 is PET tracer, half-life of 110 minutes. FDG uptake is proportional to glucose utilization by tissues, and it's based on a principle that GLUT1 receptor is usually overexpressed on many tumors cell surfaces, and it's not insulin dependent. So if you have patient imaged in the low insulin level state, that the only cells that have GLUT1 receptor will be able to pick up FDG. So that's why we have fasting patient. We administer FDG and we see uptake in the tumors and in very small number of other organs, physiologic uptake. FDG uptake is usually proportional to aggressiveness of the cancer and to differentiation. Less differentiated tumor is more likely and higher uptake of FDG you can expect. So neuroendocrine tumors are relatively highly differentiated. They still express those specific receptors. So we always image them first with MIBG and OCTREOSCAN, and only when they stop picking up those radiotracers, they lose their differentiation, then you can expect they will probably start showing up on FDG. But if you don't see uptake in these tumors on FDG, it does not mean that it's not malignant. It just means that it's not active enough to pick up this radiotracer. So it's continuum. More differentiated tumor is, more likely it is to pick up specific tracers like MIBG, OCTREOSCAN. Less differentiated it is, usually more aggressive, it will pick up FDG. And you will see similar principle in other tumors that originate from specialized cells. So, FDG, we usually acquire image at 60 minutes after administration of radiotracer. And as I mentioned, insulin level is very important when you imaging with FDG. You want to have it as low as possible. So only cells that have receptors that are not insulin dependent, that only those can pick up radiotracer. And tumor cells are the ones that have this feature. So low insulin, usually we use glucose level as surrogate for testing for insulin every single patient. And insulin, if insulin is high, then it will facilitate uptake of glucose in skeletal muscle. And you will see this altered biodistribution. If patient did not fast, then you will see everything will go in the muscles and there will be no availability of a radiotracer for tumor. So you cannot really image tumor if patient ate. Low insulin, that's your key, that's your goal for imaging with FDG. And here is an example. I had a patient with small bowel carcinoid. You can see on the left on the CAT scan, there was this focal dilatation of small bowel loop with circumferential thickening of the wall. And it showed very high uptake on the FDG scan. On the right side, you can see fused image from F18 FDG PET-CT scan. I hope it's helpful for you, and I wish you the best on your exams, and I hope that my lecture will help you in your future job. Thank you, and bye.